Hello, I'm here to talk to you today about short dental implants as non-grafted solutions. I think what you'll find is that the work we're doing here is often supported by companies such as Dentsply, Sirona, but none of these companies listed here today have had any impact on what I am about to tell you. Short dental implants are recognized and are valued as non-grafting solutions for dental rehabilitation. And my excitement about this is based on some of the work we've done over the years at the universities. I want to share with you 4 ways that we might consider using short dental implants. And these 4 applications might change the way you think about treatment planning. We will look at short implants for single posterior implants. We'll look at the use of short implants instead of sinus grafting, and the use of short implants instead of vertical augmentation. And then we will consider the use of short implants when augmentation would be required to complete a full arch restoration. When we think about short implants for single posterior teeth, we're usually talking about a simple condition such as a single missing molar or premolar. In the maxilla, the maxillary sinus impinges on the space available for implant dimensions, at least vertically. And as you can see in this example, we have used Simplant software to plan by placement of a virtual tooth and then positioning a 4.8 by 6 millimeter OsseoSpeed EV implant in the remaining bone. As you see on your right, this implant fits very nicely within the residual bone, giving us ample mesiodistal and buccolingual width of bone to protect the longevity of the system, and provides us with a great solution without considering sinus grafting. So when one sees a limited space of approximately 6 millimeters, one has an alternative that expedites therapy, and one should always consider the possibility of using a short implant versus a longer implant that would require either an indirect osteotome sinus lift or a conventional lateral window sinus lift procedure. When we think about single posterior implants in the mandible, we're often concerned about how an implant can sit above the inferior alveolar nerve without approaching that inferior alveolar canal or impinging directly on the nerve. Again, using Simplant software to place a virtual crown so we understand how to plan that implant, 3 millimeters apical from the crown zenith or the gingival zenith, we can see the placement of this 6 millimeter by 5.4 millimeter diameter EV implant fulfills the need for the placement and support of that crown. Now, this raises the question of crown implant ratio because, as you'll see, the distance, the technical distance from the implant abutment interface to the occlusal surface is almost twice as long as the implant. This is something that raises questions about possible short implant limitations. And studies have demonstrated very clearly that there are issues related to force magnification and long crown to implant ratios that lead to increased bending moments. But what we've also learned from this is that the majority of these forces occur only in lateral loading and not axial loading. And in fact, it's very clear that short implants need to be protected from lateral loading, where you can see these relatively small screws are being heavily loaded by the lateral loads in this 3-dimensional finite elemental model. What you can see is that these authors have demonstrated that the first 3 bars on your left show really no remarkable impact on axial load forces in the length of the crown. However, remarkable changes occur when one subjects these very long crowns to lateral loads. If we go forward and then think about how we consider implant components and implant systems, you really want to design that meet demands. And so when you're looking at implant diameters, you want the implant abutment interface diameter to increase with increasing strength. One hallmark of the Astrotech EV system is that for each implant, there is an individual abutment. While this requires that one has a robust inventory and understands product selection, it does provide us with increasing strength with increasing diameter. This is a rather unique feature of the Astrotech EV system, and one that is very important when we consider using short implants. Returning to the issue of that single posterior mandibular implant, we did mention that it can be used, short implants can be used to avoid the inferior alveolar nerve. But what's equally important is these short implants often avoid significant lingual cavity perforations. This is a perfect example where you can see the arrows on your right demonstrating the cortex of that mandibular concavity in cross section. And you can see that we've placed an Astrotech 5.4 by 6 millimeter implant at the bone crest, and it is not impinging on that lingual cortex. In this particular situation, the inferior alveolar nerve is actually at quite a distance from that implant, but this other issue of that lingual concavity that exists in approximately 30 to 40% of our molar restorations is avoided. So the simple answer is yes, we can use short implants for single posterior restorations. And recent systematic reviews have demonstrated this. In fact, a very recent one in the Journal of Clinical Medicine stated that there was no relationship between the use of short implants with an increased crown to implant ratio and the resulting marginal bone loss or implant survival. I should say that what we have learned is that marginal bone loss at short implants, as you see here, is less than we find at conventional implants. And in the short term, that is up to 5 years, implant survival seems to be very robust. When we consider short implants versus sinus grafting, in this case, single implants versus longer implants where a sinus graft would be required, this work done by our colleagues and friends in Zurich demonstrates very clearly that there was no difference between the use of a short implant and avoiding that additional osteotome sinus lift surgical procedure and the outcomes using a longer implant. When we think about short implants versus sinus grafting in larger situations where there is posterior edentulosum, it's also been demonstrated that short implants, that is less than or equal to 6 millimeters, are a promising alternative to lateral sinus lift or sinus floor elevation with comparable survival rates, with less marginal bone loss, and importantly, with fewer post-surgical complications. So when one thinks about this as a patient, would you prefer to go through a sinus grafting procedure, wait 6 to 8 months for bone integration and healing, followed by another 3 months for implant integration, followed by restoration? Or would you prefer to proceed without the 6 to 8 month delay, waiting for your implants to be placed? Very interesting question that most of our patients deserve the opportunity to respond to. I've thought of some guidelines for use of short implants in the Resorbed Maxilla when one is making a fixed dental prosthesis or a single tooth implant. And they include the ideas such as short implants are as effective as longer implants placed in bone grafted sinuses, and that we should consider splinting all multiple implants, and that we must have careful control of occlusion so that we minimize lateral forces on our short implants. And then one should always use caution using a single 6 millimeter implant in the unbounded dentulous space where that 6 millimeter implant might be supporting a second or a first molar as a terminal abutment. In those cases, one should be cautious about the patient they're selecting. One should probably consider the opportunity of maybe using 2 implants and bicuspidize the situation using 2 splinted bicuspids. But for the most part, the Resorbed Maxilla still challenges us with reduced bone density, and one needs to be very cautious in the application of any implant in that unbounded dentulous space scenario. What about short implants versus vertical augmentation? Now we turn our attention to the mandible, where the resorbed posterior alveolar ridge creates some challenges. These challenges are often complex, that is both vertical and horizontal. When they are only horizontal in nature, my personal preference would be to consider a horizontal augmentation, which we know works quite well. When the condition is vertical or combined vertical and horizontal, my preference is to avoid the complications and challenges with vertical augmentation and to consider short implants. The main advantage here is the reduced exposure of the patient to the risks associated with vertical augmentation procedures, the challenges of actually creating enough bone to allow for longer implants of significance, versus the use of short implants, which expedites therapy and allows one to move very quickly to implant procedures. You're saving at least 6 months in these cases, and the morbidity associated with this large surgical approach to the graft for vertical augmentation. It's been stated in several recent reviews and several papers that in the deficient posterior mandible, short implants demonstrate comparable outcomes with regular size implants in the first 5 years. And more importantly, the risk of surgical complication favors the use of short implants. In a similar way, another systematic review said that the survival rate in short implants in the mandible is similar to that of long implants, and short implants can result in a lower rate of biologic complications. So no matter where you are in the world, writing in Europe, writing in China, or writing here in the United States, as our team has done, short implants seem to offer multiple advantages over complex therapies involving a proscribed surgical intervention in either the maxilla or the mandible prior to the use of longer implants. My recommendations for the Resorbed Mandible are very similar to that of the maxilla. Use short implants to avoid vertical augmentation. I believe that, as you can see illustrated to the far right, a horizontal resorption or a horizontal deficiency might be better managed by horizontal augmentation followed by implant placement. Having said that, short implants may be as effective as longer implants in vertically augmented bone. And we, again, want to splint our multiple implants. We want to carefully control occlusion, and again, use caution using 6mm implants in an unbounded dentulous space. So looking at these images we've created here, you get some ideas that it's really quite convenient to use 2 or 3 implants to replace 2 missing teeth, depending on the function and the possible restorative scenarios available to you. This is an example of an individual we treated several years ago who also brought to us the potential risk of being a periodontitis patient. And what we chose to do was not pursue a vertical augmentation procedure, but place 3 short implants for the support of a splinted prosthesis. The plan was executed, as you can see here. These were 3 6mm by 4mm OsseoSpeed TX implants at the time. And you can see another Astratech ST implant was placed in the premolar region. The restoration was built upon Uni-abutments, which really are the strong platform for increasing our confidence in these restorations. Illustrated below, you see the advantage of these large diameter implant platforms at the level of the abutment. Here we can see that in this large 4.8 or 5.4mm implant, the uni-abutment platform, which is 3.6mm, is not dictating how the implant abutment interface is constructed. In addition, these large uni-abutments for the EV system are associated with a 1.4 or 1.8mm screw, making it the largest bridge screw available. So when creating this reconstruction, we used a substructure that was retained on these 3 Astratech implants with the uni-abutments and a superstructure in zirconia to make for a very nice restoration. The confidence in the integrity of the prosthesis is guaranteed, but also the splinting of these implants gives us a greater advantage biomechanically. So the advantage of splinting short implants includes prosthesis-related factors. They're simple restorations to construct, to impress. They're simple restorations to deliver. And they make supportive implant therapy and maintenance much simpler than individual implants that would be challenging to remove and then replace in the proper orientation time after time after time. The disadvantages, of course, are often patient-related, where they might complain about their desire to floss their individual teeth, or the psychology of not having individual teeth, but patients need to understand they lost their teeth probably because they weren't flossing, and they probably don't understand that the implants will not experience movement. They will not feel just like natural teeth anyway. So we try to counsel our patients as to the relative mechanical advantage of splinting short implants. And one might argue that restorative simplicity issues could be a disadvantage in some people's hands. We use short implants today as contingency plans when we have failed bone augmentation. And so the unfortunate thought is, well, what if we'd have never grafted this site? But in fact, the site was grafted, the graft had failed. And so the contingency was to use short implants. As you can see, we've placed 5 implants in this reconstruction. And these 4 where the failure occurred are 2 3.6 millimeter regular length implants. And then we used a 4.2 by 6 millimeter EV implant and a 5.4 by 6 millimeter implant to retain this prosthesis supporting premolar and canine function. All of this was done without having to subject the patient to yet another failing bone graft. And again, the restoration of choice here is a screw retained restoration supported by the uni-abutments. Of course, when angulation problems present themselves, one has the opportunity to move to 17 or 30 degree smart fix abutments. Short implants do solve problems. And more importantly, short implants do allow us to think about alternative treatment plans. For example, this case was really challenging after extraction and not having sufficient bone volume, but the solution was really quite simple when we recognized that we have valuable tools in our armamentarium. So in this maxillary reconstruction, instead of delaying therapy and allowing us to not pursue or preventing us from pursuing an immediate load procedure, we were able to go through the process after edentulation and interim denture wearing to place these 6 maxillary implants with the shorter implants, the 6 millimeter by 5.4 millimeter EVs in the posterior regions, allowing us to move forward to eventually provide this patient with 2 complete arch restorations built on zirconia. These short implants do provide new solutions. And again, when one allows oneself to think about the use of 6 millimeter implants, a remarkable amount of bone is available to help move patients quickly through these really challenging situations. Now, the last thing I'd like to mention is that we have investigated the use of short implants as non-grafted solutions for full arch restorations without the use of tilting implants. So in a thesis conducted by Julie Alpers, one of my graduate students while I was at UNC graduate prosthodontics, she treated 21 consecutive placements trying to place 4 implants in most maxillas. You see 3 patients had 5 implants. And most of them, well, half of them were 6 by 4 millimeter implants, the other half were 8 by 4 millimeter implants. And these were all restored using monolithic zirconia fixed dental prosthesis, with 11 of the restorations opposing a natural dentition and 10 supporting implant-supported fixed dentitions. The results were 3 early implant failures for a survival rate of 97%, and this was at 27 months without an implant failure since loading. The fixed partial denture survival at 12 months was 100%. And so when we think about a case like this, not a patient included in the study, we can see the atrophy and we can begin to question how we can treat this maxilla without grafting or the use of zygomatic implants. But what we chose to do was first design a new denture and then move to Simplant, where we could scan that denture and begin to understand where the implants needed to be placed and if there was available bone. And through the use of Simplant and recognizing that we have in our toolkit these 6 millimeter implants, we were able to place 4 or choose to place 4 millimeter by 6 millimeter OsseoSpeed TX implants. What happened here was a simple guided procedure directed using Simplant guides. And the guides worked very well. The implants integrated, and we were able to move along to make an impression and then use the Atlantis Hybrid titanium option to create a framework for our acrylic metal hybrid prosthesis. You'll note that this prosthesis is designed to support individual teeth, and the height of this titanium bar belies the amount of resorption that we were dealing with. The acrylic veneer was applied, a little characterization was added, and the patient ended up with a remarkably attractive and stable and successful prosthesis without the need for grafting, and moving her very quickly over a period of 6 months from the first point of surgery to the delivery of the final restoration. Had we gone through a grafting procedure, she would have likely been edentulous for some period of time and not yet had implants placed. So the result here is, again, 4 small implants placed in the available bone. We've used 4 uni-abutments. We've used the Atlantis Hybrid titanium bar, and then created our acrylic hybrid prosthesis for success. These shortcuts to success are now being repeated in our clinic. Another example, very similar to the one you just saw, in fact, remarkably similar. Again, avoiding the sinuses, avoiding grafting. Certainly, sinus grafting is an option here with posterior implant support. And then able to go through the process and have successful integration with zirconia prosthesis delivery 6 months later, and then a 12-month follow-up to the prosthesis placement shows no change in the bone surrounding these Astratech implants. These happen to be EV implants, and the results very acceptable to both the clinician and the patient. So let me summarize our brief chat today and just urge you to please use short implants, or at least consider them in all your treatment plans. It's funny, short implants finds new bone. I will leave it at that. The OsseoSpeed EV 6mm implants are designed to support function, and they come in multiple diameters that allow you to apply them much more broadly than we could 5 years ago. They are supported by promising 5-year data, and I will suggest that when there are not other mitigating risk factors, these implants perform exceptionally well, even in the edentulous or posterior partially edentulous maxilla. It's clear from many studies that patients prefer the expedited therapy, avoiding augmentation or grafting procedures, and using short implants is preferred by patients who have participated in these studies. So let me just close and say, consider using short implants when you're looking at single posterior teeth with limited bone dimension. Consider short implants to avoid sinus grafting. Consider short implants to avoid vertical ridge augmentation. And consider short implants whenever you're in search of a non-grafted solution for full arch reconstruction. I hope this has been informative. I hope you will think about using short implants. I think when you're interested in a short implant, you'll consider using these OsseoSpeed EV short implants because of the mechanical advantages they have and the well-known responses to bone these implants produce. If you have any questions, my email is in the bottom right-hand corner of this slide, and I look forward to hearing from you should you have any questions. Thank you very, very much.